Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Welcome, everybody. I am so excited to have this wonderful guest on the show today, Dr. Sandra Kahn. You've probably all heard of her. I'm hoping you read the book Jaws. I read it a while ago, and now I have the audiobook, so I'm listening to it again, so absorbed in this. So we're going to talk about the book Jaws as well, but I'm going to give a brief introduction about Dr. Kahn, who is a graduate from the National University of Mexico and the University of the Pacific School of Dentistry in San Francisco, California. She began her work in orthodontics with a specialty in physical anthropology at the University of California, Berkeley, focusing her studies on human craniofacial growth and development. After 22 years of clinical experience in orthodontics treating thousands of patients, Dr. Kahn was not satisfied with traditional orthodontics as a solution for treating her own children. So in 2013, she retired from quote unquote traditional orthodontics to focus in orthodontics related to health, airway, with a concentration on pediatric prevention of long-term obstructive sleep apnea, which is what all of our motivation is right here, right now. We've got to get these kids early and think from an airway-minded focus. So Dr. Kahn is the author of Let's Face It, A Guide to Optimal Health, Facial and Dental Development, author of 𝐃𝐈𝐒𝐂𝐋𝐀, Good Oral Posture Exercises, the book Jaws, which I just mentioned, the story of a hidden epidemic, Breathe 4.0, which we're going to get into today, which I'm very excited about, and Orthodontics Protocols. She translated Dr. Mew's book, The Cause and Cure of Malocclusion, developed the Kahn-Bow protraction device, which I want to talk more about as well, the Orthodontics Up Locker and the Up Lock Pacifier Series, Nasometer, and Nasometer Flux. Multiple scientific publications include index journals in anthropology, otolaryngology, and bioscience. Dr. Kahn's approach is to treat the entire face, not just the teeth, and she's been invited to serve on craniofacial anomalies teams at both Stanford University and the University of California, San Francisco. So I thank you so much, Dr. Kahn, for being here. Appreciate your time.
Thank you.
So, okay, so I think I learned about you many years ago when the book Jaws came out. What year did you write the book or co-author the book Jaws?
Well, that was the work from 2017, and it came out in 2018.
Okay, that book is transformative. I urge any provider, colleague, practitioner, even patients to read that book. I think that book is so important for everybody to understand as the foundation of this hidden airway epidemic and how our jaws and our facial structure have changed over time, really the root of malocclusion. A lot of that book talks about, in the beginning part, how the change from the pre-industrial revolution, how our diet, and not just diet meaning the foods we eat, but the textures of the foods and our decreased chewing has changed the growth and development of the face. Can you talk a little bit more about that and who your co-author was in the book and that concept of mastication and how our faces have changed due to our food types?
Okay, so it's difficult for me to talk about work from 2018 because science is ever changing, and 6 years have passed since that book was published. But books, when they're published, they've been in the mix for at least another year. So this is a 7-year old theory that it's been debunked, basically. The evolutionary concept that what we're dealing with as far as the shrinkage of our jaws, it's evolutionarily is not genetic, it's mostly environmental. Of course, environment and genes are tightly knit, and we talk about, let's say, a rectangle, which is the perimeter is the height and the length, but one is a lot bigger. So we think about 20/80, 20 genes, 20 and 80 environment. So if we're thinking of nurture and nature would only be 20%. And that's pretty much still solid. However, this chewing stuff is the low-hanging fruit, but it's really overrated in what we believe is the real culprit. And my head explodes because for the last 4 years, I've been working with Dr. Engelke, who's really a genius, who deserves the Nobel Prize really for medicine, triple PhD, surgeon, ENT doctor, and then maxillofacial surgeon, dentist, phonoaudiologist, 3 different professions in one.
Repeat the name. Who is the name?
Wilfred Engelke.
Okay.
And so I've been working, he's my co-author in Breathe, in the book Breathe, and I've been working 4 years with him, and I had to really turn around and look at things from the physics standpoint of view. But when you look at physics, and we live in the planet, and we know we have our blood pressure, and everybody knows about that, and there's pressures in our mouth, in our airway system, as we take oxygen, and we get it into the cells and the lungs. There's pressures, there's gradients, and it all has to do with physics. And I've been having to understand physics. And when you start looking at dynamics of fluids as opposed to mechanics of solids, it all completely changes. And we're still thinking of mastication, which is solids. And mastication is hard forces that are sustained very quickly. So when we talk about growth and change in your bones, we have to think about more lighter forces that are sustained for longer periods. That is posture. And chewing is not necessarily posture. And everybody looks at what I wrote in JAWS and says, oh, let's chew, chew, chew. Although the world is changing now, people are obviously listening to what I'm writing and what we're talking about, because now everybody's talking about suction and swallow and sustaining that situation right after you swallow. But still, people are not going back and understanding physics. And when people tell me, oh, we've taken care of the airway, and I start poking about what they're taking care of, it has nothing to do with the real culprit, which is the nose. And my book that I'm writing now, with same writing team from Stanford, Dr. Ehrlich, and we have a lot of people that are contributing, like Dr. Jesus Rangel, who's our ENT, who he's beyond brilliant, and Dr. Engelke, obviously, and our team, Robert Sapolsky, Mark Feldman, the same consultants or the same writing group that we had when we did JAWS.
Okay.
But we are really, really looking at this new book, and we've now labeling it a prequel to JAWS.
Ooh.
So we are writing the prequel because nose is first. And people look at JAWS and they think this is a full story and this is what it is, and we need to do this and we need to put tape on the lips. There's things that that we need to do to really be where we need to be, and it's not what I wrote in JAWS. This whole thing with the tape, I did write about it in JAWS, but I didn't know what I know now. But that should be pretty clear to anybody that knows anything about science. There is nothing very few things that are written that 7 years are still the same. If you look at anything that has to do with neurology, it changes so fast with the working MRIs. What I learned in school doesn't apply anymore. And so the nose needs to be considered. And I don't think the nose is on anybody's radar. When people tell me, oh, we took care of it, I go like, what did you do for the nose? No, we did expansion, we did posture, we did Gopex, we did tonsils, we did, and I go like, but we did frenum. I said, but what did you do for the nose? And they're like, huh? What?
Mm-hmm.
And I developed the nasometer because people don't really know that there's an issue in the nose. And I don't know how deep do you want me to go into this, but I'd love if anybody here listening knows anything about physics, there's a model called the Starling model.
Mm-hmm.
And if you look at the Starling model and you look at the nose, the pharynx, and the trachea, it's a solid, then there's a collapsible, and there's another solid. And if you understand how gases and fluids travel in the Starling model, you realize that the problem is not in the mouth, it's not in the size, it's in the fluids and how they go in through the nose. So if that solid tube gets blocked, even partially, it's going to create collapse in the pharynx. And no, I mean, I heard a very famous ENT, I won't say his name, posting, the things about angle key with the tongue and I was like, okay, but he's an ENT. And the nose is not in the vocabulary, not a single thing in his whole, not in that post, but in all his posts, not even a mention of the nose. And it's a shame because we really know what to do, but people are not willing to do it because we are not very, we're not being very concise and specific about the nose is first. Everything else, expansion, chewing, feeding, swallowing, anything you want to do, great. But nose is first. And nobody's putting the nose in its right central and forward place. And
Right.
the fact that your nose works in the day and you're like, my nose works, that doesn't mean it works at night. The night nose, and Dr. In my book for orthodontics, I don't know if you have the protocols book, we actually wrote 4 pages, from Dr. Rangel, and he coins the term nocturnal nose because it's a different organ that has different requirements than the day nose, where your brain is awake and your brain is helping you and your brain is fine doing that, and you have gravity. There's a lot of things going on in the daytime nose, where the nocturnal nose, the brain needs to disconnect. So the nose needs to be independent from the brain at night. So the nocturnal nose is a different organ. And it doesn't seem like even the very, very smart people that are smarter than me at sleep departments or CPAP doctors, they're not addressing the nose.
Hmm. Yeah. And that's interesting. So, are you familiar with Karen Parker Davidson? She talks all about the nose and does a lot of studies on nose breathing, rhinomanometry. Can you talk about your role with those devices? And also, you mentioned the nasometer. So, I'm not familiar with that. Can you explain what that is?
Who is it? Karen Davidson?
Karen Parker Davidson.
Oh, okay.
I think she's on her, I just listened to one of her lectures. She works with, coordinates a lot with Bill Harrell, but she is a nurse, and I feel like she's on her 2nd doctoral degree and her 4th master's degree or something. And she's very into the nose as well. I think she says the nose. And that's her saying. But one of her recent lectures, which was really interesting to me, she said, when you are sitting upright, and you recline back at 60 degrees inclination, you have the greatest airflow resistance. When you are, so like she was saying, sitting in, like you see cartoons or old shows where the overweight man leans back in the recliner chair and starts snoring, substantially. When you are laying flat on your back and you elevate at an elevation of 30 degrees is when you have the least amount of airflow resistance. And it's interesting because I don't know where I heard this, but I heard somewhere about 25 degrees of elevation is really good for our patients to elevate the head of the bed about 25 degrees. And so now I'm thinking, oh, that 30-degree number. But she talks a lot about the nose. We need to have really clear nasal breathing as you're talking about that Starling resistor model to decrease collapsibility at the lower parts. And it is
Middle
absolutely
part,
the
middle part.
middle, lower than the nose, but the middle at the pharynx,
Because
right?
we have the trachea, which is not collapsible.
Mm-hmm.
So the pharynx, all of this is collapsible.
Yep.
Nose is not because it's solid. Then we have the collapsible, it's like a spring.
Mm-hmm.
Then we have the non-collapsible, and that's a
Yep.
starting model.
Exactly. So the middle part, I was just meaning like lower than the
Yeah.
nose part. So when you're breathing through your nose, we want that clear open airway. And it's funny we're talking about this because I have a patient later today that I'm going to talk about this as well. But I always take a straw And I take a flexible straw and I hold it horizontally at my nose so it kind of follows my nose to my throat. And I explain this to my patients that we want a clear, open airway. We want a wide tube that's clear, good, clear airflow. And we also want that tube to be strong. And that's kind of the role of the muscles and the myofunctional part. But when anything is providing some resistance at any part of that tube, and I talk about the nose, that is going to cause that airflow to increase, and that's going to increase collapsibility at the pharynx, at the throat area. And the nose is definitely underrated. And it's interesting from your book, Jaws, which has a lot of focus on chewing, to now a shift, which is going to be the prequel, which is really cool, that we're talking about nose and what else? Muscles. Is this the book Breathe 4.0? Is this what we're talking about?
No, the one we're writing, the working title is nose, capital N, capital O, for
Okay.
nitric oxide,
Uh-huh.
nose. Although that's the working title, but
Okay.
as you work with all these teams that we're working with, and we're working with other titles now because that was a little. I mean, we're still going to keep nose with capital N, capital O because nitric oxide is just beyond important. But with the Starling tube, it's really, I mean, I had no idea about any of this. I'm an orthodontist, and I thought I knew physics because I knew the forces, the vectors, but I knew nothing about these models, zero. And so I've been studying physics now, and it really has changed everything that I thought.
Mm-hmm.
Because if you don't unplug the nose, stop messing around. And I have my WhatsApp groups and messages completely full of students that ask me about their children. And I said, have you looked at the nose? And they said, well, what do you suggest? And I said, reduction of turbinates. I haven't even seen the kid. Adenoid and reduction of turbinates. They said, well, other than that. And I said, other than that, do whatever you want. Like people will not do turbinate reduction. And the expansion's great, but what expansion does is it enlarges the room. It enlarges the room, so it appears that the adenoid and the tonsils are not in the nose, but the adenoid and the turbinates are not going to be crowding the house if you make but it doesn't mean the furniture gets bigger, right? And the furniture, the things that live inside the nose are crowded. So expansion helps you, but the turbinates have mucosa whose job is to produce mucus. And parents, I was just invited to the international pediatric meeting in Mexico, and it's really crazy how many parents are obsessed with washing the nose and
Mm-hmm.
removing and unplugging the mucus. And that's not unplugging the nose. Unplugging the nose is reducing whatever's causing that obstruction, not the consequence, which is the mucus, which we know we need. I mean, I had kids, my kids are 21 and 23. I never once washed their nose. It wasn't done 20 years ago. It was not a fad, which is now. And it really doesn't make any sense, especially with saline, because saline, the Sumerians invaded salting to dry up. So when you put in a rhinoscope and you see after saline, you just see dryness everywhere. And that's, nose is not meant to work in dryness. So if you're doing this, and I'm not an ENT, so don't take this as a law, but I learned from Dr. Rangel, who says this washing of the mucus out is insane. You need to figure out, and also blaming everything on allergies doesn't make any sense. One of the examples in our book is, I'm from Mexico. I can eat as many chiles as you want. No problem. I'm not allergic. But when my mom is making her mole and it's frying or toasting the chiles, I walk into the kitchen and I start crying. My throat swells. I'm not allergic, but I'm overwhelmed with the particles in the air of that chili because she's toasting them, right? So this is what happened with kids. They don't necessarily have allergies. It's just there's so much stuff in the air that wasn't there before that their noses are overwhelmed. And what happens with the turbinates, they're covered by mucosa and submucosa. The mucosa produces the mucus, it has the cilia that help filter. I mean, there's so many things happening in the mucosa, but it's distended. It's not inflamed. The turbinates are not inflamed, they're distended because they have to filter so much more stuff. So with radio frequency, when Dr. Rangel works on the noses of children, he goes in with the radio frequency beyond the mucosa into the submucosa and reduces the size to allow filtering to become efficient again. And it is a procedure. And parents and doctors don't want to do it because it's easier to send for a frenectomy or for palatal expansion or even tonsillectomy than to work in the nose, because the nose, if you mess up the turbinates, you can have an empty nose syndrome. It's too much of a risk. And we need to have providers that are good at what they do. I would send, if I had anybody that had either snoring or sleep apnea or somebody close to me, I'd send them to Mexico to Dr. Rangel. I would not send them anywhere else because this is a guy that's been doing this for 30 years and he has, I mean, he's done surgeries, no surgery on 6-day-old babies. If the nose doesn't work, you got to fix it. And parents say, well, he's too little. And I heard him say to a parent, if he had an appendicitis, you wouldn't say, oh, he's too little, let's do it, let's take care of the appendix when he's older. No, children need to breathe now, not when they're older. And the nose has to be taken care of, and it has to regain its central forward place, because not for coincidence, it's in the center and in the front. We have to give it priority. And I'm in a crusade here. I wrote down the name you just gave me of this nurse, because we need to get together and say, we need to demand better therapies for the nose.
Yes, you definitely need to talk to her. So this is interesting because it's not, you're saying not nasal hygiene so much, but actually fixing the structure. And the structure might be distended or enlarged because it's working harder to filter out environmental toxins or factors, right? So do you feel like this issue that a lot of people are facing with nasal obstruction is due to like pollutants in the environment, or and the solution is like a frequency ablation? It's always some sort of invasive procedure?
Look, I'm not going to give a cooking recipe to everyone. Every case should be evaluated on its own right. However, getting people to a situation of health, we don't talk about prevention, we talk about fostering health as opposed to saying preventing a certain thing. But to get a healthy environment, the nose has to be breathing has to be 95% effortless at night. 95% effortless means there's very little resistance in the nose. And what do we need to do for that? Obviously, if you are fully grown, if you're past 15 and your nose is too small and the palate is high and you've been a mouth breather and your septum has deviated. Also, deviated septums, they happen because the palate doesn't descend. So the septum, when it comes the time to grow, it has to grow somewhere. So it grows to the side. It's not traumatic. But most of us have deviated septums. If you look at everyone, look at my nose. This was smaller than others. And I have a nose. But we all have something because we didn't swallow well, we didn't chew well, we didn't have all the things together. We were given a little spoon with mush during weaning, and that obstaculates the ability to create vacuum. I mean, there's a lot of things that we went through. So almost everybody has nasal problems. It doesn't mean you have to go in and fix the septum, but it means you have to do whatever it takes to have a 95% effortless nose at night. So if that's the case, then, you have to do what you have to do. And sometimes there's adenoids, sometimes there are turbinates, sometimes you just need to use oil. Instead of saline, oiling, Dr. Rangel recommends sweet almond oil to moisture. And of course, you can remove the mucus, but not like, flushing it out, just removing whatever extra there is and leaving the mucus to do its job, but making sure that, whatever's inside. And definitely going to an ENT rhinologist that prioritizes the nose. And I don't know if we have any, because I don't have any here in the Bay Area yet. And I'm trying to find one, but, doctors are really overwhelmed and the medical system is not the easiest to deal with, but I do have fantastic people in Spain and in Mexico. And I say, it's worth going to them, even if you have to make a trip out of it, because to get a well-functioning nose will spiral everything else into the right place. Obviously, if you already have huge palatal collapse, we have to deal with that, and we have really good techniques to do that. But that should be in addition, taking care of the nose, not instead of.
Right. Yeah. It's like, don't forget about the nose, prioritize that. That is of utmost importance. There's other factors, but we can't leave that out. That's where the breathing starts, right? If we're a healthy breather, we're breathing through our nose. That's where the airflow enters, and we need to make sure that is fluid airflow, no resistance, decrease the amount of resistance due to structural pathology.
Yeah, and you asked me about the nasometer, and my nasometer is a device that I created. It's not available because I haven't been able to raise money for it, but it's this device right here. I don't know if you people are
Okay.
watching, but this basically just measures the resistance. I put it on one side, it measures how hard it's, how much pressure. It's not really measuring the resistance. For the resistance, we have the nasometer flux, because it's flow and pressure. This is just pressure, but it gives you how hard your lungs have to pump to get the air in. So if you have more than 4 millibars of pressure, then you need to look into why is it hard. And it also helps you see which side, because then we have the nasal cycle, so it's not always the same. So the nasometer will tell you if your nose has issues. And I find that most of us have issues in the nose. And just a little oiling or decongestant. There's really good stuff now over the counter. We were just working with a Colombian dentist and her daughter 4, and she called us back and says when she gave the daughter the decongestant, it was the best night in her household since she's been born, because she slept all night. That's not, the decongestion is not a long-term thing, but it means there's something in there that needs to be taken care of.
Right. And the nasometer, is that like blowing some air into the nose and feeling the
No, no,
pressure?
no, no, no.
How does that work?
This just measures the pressure. So if you
Okay.
put it here,
Mhm.
it's blocking the side,
Okay.
and the air is coming in and out only on the
Okay.
side.
So you breathe in and it
Like
measures.
you just take 5 breaths, and then it gives you a number.
Okay.
So you take 5 breaths on one side, 5 breaths on the other, and you have that number. And once we have a number, we can say, okay, we need to lower this number. We need less resistance. I got to be careful. It's not resistance, because for the resistance, we need the nasometer flux, which also has a venturi that measures flow. This doesn't measure flow, so we don't know how much air is going in. So
Okay.
it only tells you at rest how hard it is, because you can force yourself, like with children, we like to measure when they're asleep for babies. So we give them our pacifier, because we have our uplock pacifier. And when they're asleep with the pacifier and the mouth is fully closed and they're asleep, we can measure. So that then it's easier to know what's going on when you're asleep, which is critical. First 1,000 days are insanely critical. The more we learn about it, the more we got to get that nose working. And 1,000 days doesn't mean 3 years. 1,000 days is 2 years because of the gestation. So I didn't know that. I thought, well, I have them till 3. No, because the 9 months of pregnancy are included in those 1,000 days.
Oh, interesting.
So we got to get the mom breathing right in those,
Yes.
first days, and then we have 2 years to get the nose right, and then we're free. But once the baby's 3 or 4, it's an uphill battle.
Yes, we got to fix these things early, identify early. I remember my older son had a lot of nasal resistance from birth. And then when he would nurse, like milk would even go in his nose and he'd have nasal congestion. I had to use the nose Frida to clear his nose so he could breathe. I mean, and that was, day one. It was a uphill battle. So parents need to be aware of these things so we can help these children get help early versus um, you know, just treating symptoms, like figure out what's going on and get to the root cause. And I know breathing through the nose, there's more resistance than when you breathe through the mouth. because that air does need to slow down. And so the turbinates can do their job of warming, filtering, humidifying, that whole process. So it's interesting and totally beyond my scope of like what amount of resistance is normal and when does it become a problem. And so I'm sure, that's probably addressed in your book. And maybe these ENTs who prioritize the nose have ways to measure and talk about that. How would somebody find an ENT who like prioritizes the nose? I wonder what you would how you would know.
Well, first, let me congratulations, and you're cementing my opinion that SLPs have the key to change the world because
Oh.
it's real. I mean, Catherine, that our SLP here in the Bay Area, she's beyond amazing. And I now do think that SLPs, because we're doing a lot of things with swallowing and the barium, the video fluoroscopy with the swallow and the barium. And when I interact with the SLPs, I realize that they're a step ahead from everybody else, especially when it comes to breathing, because you guys have such a complete training and you see it, everything from the very beginning. And you SLPs really do have a focus on an end where, I mean, I don't want to speak idly or bad of any profession, but myofunctional therapists and orthodontists, we tend to think, okay, you'll get braces again, or this will help you, but we're always blaming the patients for not doing enough. Where SLPs, they know, they have markers that are clear. So you come from a different background. And the stuff that you're saying about the nose, it's blowing me away because you're even ahead of me in knowing the stuff. When you say, we have to make sure that the air gets slowed down. And that's part of what we're writing in nose now, is that the mouth has two jobs. Mouth breathing is not bad. We are made to mouth breathe. It's perfectly fine. It's what makes us human. Mouth breathing is fantastic. But the mouth has two jobs. When it comes to bringing air from the environment to our lungs, the mouth has two jobs. The nose has five. So if a machine only does one thing, it can move very quickly. If a machine has a lot of things to do, it has to slow things down. And that's what we call baffling. And baffling the air to be at the right temperature, to be at the right moisture, to have nitric oxide, to be filtered properly. I mean, these jobs take time. So the nose is designed to slow things down. Having a large turbinate is not a bad thing, because if you cry or it's cold, this is what they do. Mm-hmm. So they're not inflamed and they have to slow down the air, which makes total sense. Two jobs for the mouth are very sympathetic. They're fight and flight. So the nose has to do volume and speed. Only two jobs. When you need a lot of volume very fast and the tiger's fighting you, or you have to either fight the tiger or run, the mouth comes in and gives you a volume, tremendous volume and tremendous speed. So you get all the oxygen and your cells get the glucose they need and you get the oxygen and it all happens fantastic. I mean, the body's amazing. When you want to be in parasympathetic, which means health, because it's rest, repair, digest, in parasympathetic mode, which is where we want to be ideally more than 90% of our time, we want to be breathing very easily and taking in a little air and getting all these 5 things that the nose have to do very carefully and very efficiently. So we want to slow down the air or we want to speed it up. And, machines have different modes, right? My hair dryer has, when I just want cold air for something, I have a mode in cold, and then I have the mode in hot. And then I have, when I'm in a super hurry, I'm like, probably burning my hair and I'm drying it really. So for different things, we have different modes. Breathing is the same. We have a mode for volume and speed and another one for, just baffling, slowing things down to get the right things for health.
Yeah. And again, just to kind of summarize all this, we can't put the nose last, put that first. And I always test my patients looking at the nares. I refer most to ENT if there's any mouth breathing or any comments where the patient might feel like, yeah, I can breathe through my nose, but it's not easy or it doesn't feel good, or when I go to sleep, I feel more anxious. A good ENT referral is definitely important. And we do like the caudal maneuver. And what are your thoughts on like nasal, like breathe right strips or nasal dilators, things like that? No, because it's not fixing the structure, it sounds like.
Yeah, let's just look at the Starling model. We go back to the beginning.
Yeah.
If you look at the Starling model, it doesn't matter if you can get an elephant through the door. So these dilators, and there's definitely a psychosomatic, effect that's, we know that the placebo effect is absolutely physiological. It's not made up. So if you put a breathe right or a dilator, people say, oh, it feels fantastic.
Mhm.
But it's a placebo effect because you're not, if you understand the physics, the Hagel-Pascal laws and the Venturi effect, and I mean, there's so many things that are injecting air all the way to the lung. And if we don't, if we understand those principles, you'd know that a dilator is going to do practically nothing unless you have a collapsed valve of the nose. But these things, and parents and patients are so happy to do things that don't involve invasive procedures.
Yes.
I have empathy. I understand it. I didn't want to do that with my kids either. And both my kids, my son had no surgery, my daughter had bimaxillary advancement and nasal surgery. And I didn't want that. They had that, my daughter at 15, basically that's when your airway is fully grown. So we don't want to do that. And when you ask me, how do you find one? If you figure out, let me know.
Yeah.
I
Well,
even, I was very angry at Dr. Rangel because he's in his 70s. And I said, are you training anyone?
yeah.
Same thing with Dr. Alfaro in Spain. He's a maxillofacial surgeon, ENT. He's older than me, in his 60s, I think. And I said, are you training anyone? He says, no. And same thing with Dr. Engelke, who's in his late 70s.
Hmm.
They're not passing the baton to anyone because the healthcare system is not conducive. And I mean, young people, unfortunately, they think they know everything and they figure something out and they stay with that. And it's very hard for these incredible doctors that are not leaving anybody behind them. And
Yeah.
I like you said, I'm gonna look up this person, this nurse, to figure out. But I've seen other nasal people, and their focus is not really on this Starling model thing where you have to clear what's inside. You
Mm.
can't deal with stuff, and you can't just wash it, and you can't just use all kinds of techniques to do things when you're not clearing the passage of that air and the submucosa, leaving the mucosa free to create the mucus that we need, but reducing the, and you said something about, is this, are the turbinates reacting to pollution? Not necessarily. They're reacting to an increased number of particles. And we're very careful, especially with my team at Stanford, with Dr. Ehrlich, is not to say that this is pollution. There's microplastics, there's all kinds of bad things in there. But there's normal things in there that are not pollution, just like the example we gave of the chilies. The chilies are not pollution, but there's so many of them. And this is what happening. Probably your baby, as your son was born, there was stuff in the air that wasn't there 100 years ago, because we have created materials like the flat screens for our phones use something called europium, and that's a rare earth, and there's submicro particles, and we have a lot of them, which were a few in the air, but now that we have high-speed rail, the particles are a lot smaller because we want high speed and we want lighter things. So
Yeah.
all these light materials are now in the air, and we
Right.
have to filter them. It doesn't mean that they're pollution. They're particles, and we have to talk about particles because there probably wasn't pollution where your baby was born, but there are more particles in the air. That's just the
Yeah.
places that we're living now.
Yeah, the human body has to work harder basically to be healthy. And then that combined with our shrinking jaws and face means there's less airflow going in, more body working harder, and the system is prone to breakdown. I would just kind of assume.
And really, we're not that, we go back to exercise. We're not exercising as much as we need. You know, Daniel Lieberman just came up with a new book. It's called Exercised. And Daniel
Okay.
Lieberman he's amazing. We worked with him a little bit on Jaws,
Yes.
and you know, he's really one of the people that really understands the human predicament from beginning. And in his book, Exercise, he basically says that's the one treatment that has no side effects. It has no it's the only one. And we should see it as a therapy. And we gotta get out and exercise properly.
Yes.
Not marathon, not biking for, you know, days on end, but the real exercise. And when we look at the blue zones and the centenarians, we know they're doing gardening, they're outdoors, they're under the sun, they're, you know, eating whole foods in smaller meals and different type of sugars, less processed. I mean, there's so many things that we're focused on, but really exercise, being outdoors, and if we walk 10 miles every day, we would have no disease.
Back to basics, right? Just be outside, you know, walk, move,
Yeah, but
breathe the air.
these parents that are obsessed with their child nose, they have their child, I see them all the time. And these kids have bellies that belong in 50 or 60-year-old men, not in children that are 10 years old. And the parents are still wanting to take care of the nose and the teeth and the expansion. And it's not adequate for me to say, get your kid out of the house and exercising for 2 or 3 hours every day. And I'm very strict with myself. I exercise 2 hours religiously every day. And, you know, it really has changed my life.
Yeah.
So it's hard. I mean, I have empathy because the lifestyle of families is different now, but we're just, even, you know, a little bit, we're still dealing with overweight and fat deposits. And we know now that muscles act as glands. So I'm 60 almost, and I'm creating more muscle because my muscle is a gland that's secreting hormones. And so I need more muscle. We lose 10% of our muscle mass every decade.
Mm-hmm.
So what am I going to look like at 60 if I'm not building my muscles every day? And so
Mm-hmm.
I'm doing that because I want to foster my health. Doesn't mean I want to live forever, but I want to have a health span, a longer health span. So I want to, when I want to die complete and healthy. I don't want to be breaking down for the last couple of decades of my life.
Yes, we need to be out, breathing the air, working the muscles, whole body, whether it's gentle weights or using your body for resistance, and also, you know, aerobic type exercise with nose breathing. I'm a runner also, so I breathe when I run with my lips closed, but I didn't used to until I learned the importance of that. And now I'm like obsessed at everybody I look at that I cross paths with when we're running. And I'm like, mouth open, mouth open. Like almost everybody has their mouths just hanging open.
Hold on a second. In Breathe, we have a whole chapter on sports. And when you're running, you're supposed to mouth breathe. This thing about exercising with like tape or with a closed mouth is not necessarily so. It depends what kind of demands you're putting on your body. You don't want to nose breathe. Remember, the nose has 5 jobs and the mouth has 2. So if you're going to be running and you're at the last part of a race, and when we do our studies in Germany with athletes, we work with soccer players, professional soccer players, and we talk about the switch point. So you want to delay that switch point. The more fit you are, the later you get to that switch point, and then you want to go into recovery as fast as possible. But when you're running, you can breathe through your mouth. That's what you need, the volume and the speed. But
Well, I feel if you're anaerobic and sprinting, you know, and out of breath, you're gonna have to breathe through your mouth. But I prefer to be at a pace where I can run comfortably, breathing through my nose. And when I made that switch, I felt like I could run longer, I could go faster. Um, it was an incredible switch. I felt better. I probably was, you know, breathing, producing more nitric oxide. My got less muscle soreness. So I feel different. I wouldn't even dare to breathe through my mouth when I run unless I'm out of breath. So I was talking to my parents on the phone when running and I was,
you
yeah.
can learn to optimize your physiology. So why do we mouth breathe? We also have to cool ourselves off. And there's a great essay from, I think it's from Radiolab, where they talk about why humans became the dominant animal on the planet. And it's because we have the ability to cool off while we're still exercising. And that's why we could outrun every other, humans can outrun any other animal on the planet. And why is that? Because we can cool ourselves off. So you don't want to give up on your cooling off when you're reading, when you're running. And the nose is not going to cool you off. So sometimes, and it's all really well described in our Breathe 4.0 book, and it just tells you, there's a rhythm you can have to cool off and still take air. There's no real mouth breathing in nature unless you are underwater or if you have something mechanically hold. There's always a combination of nose and mouth. It's very rare that we're mouth breathing. So there's always air coming in through the nose. So you can optimize your running if you figure out what your demands are. So your demands are different when you're going up a hill than when you're in flats. And if you're going to do a bike ride and it's going to be 24 hours, you're not going to kill yourself. I just went watching the Olympics and you see the marathon runners and, they have this, that they know when to go slow, when to cool themselves off, when to, put and they want to close this run and then win the medals, right? And the female marathon was amazing. I watched the whole thing. There were 4 women there was nobody else after them. It was like miles, I don't know, really far. There's 4 women at the front. And you could tell that they all wanted it, but they were all pacing themselves so that they knew how to optimize their run so that at the very end they would give 100%. And if you think that they're going to give 100% with a closed mouth, then they're not really, they're shortchanging themselves. But the pace is important. So you can optimize yourself either at that Olympic level or at our, common person level, like you and I who exercise for health. But learn how to cool yourself. The cycle of 2 breaths in through the nose and 1 longer one through the mouth for longer periods, it does get you into cooling yourself off. So don't make a villain out of using your mouth for air because it's there for a reason. And that cycle, and I remember in the 70s, they would say you run like that. 2 through the nose and 1 through the mouth. 2 in through the nose, out through the mouth. And we have a page in the book where we explain how the physiology of that is, and it's cooling yourself off because you're sweating, but you're also cooling yourself through the breath. So it's very interesting when you start looking at the science, and we go back and grandparents, they always knew it. In 100 years ago, they probably knew everything that I'm finding out. They just knew, automatically. And my grandmother, I remember she said to my mom, all you have to teach your kid, I'm from Mexico, right? She says, teach your children how to swim and English. Everything else they can learn on their own. But teach them how to speak English and teach them how to swim. And then your job as a mom is done. And let them run outside. It just sounds so much more true to me now, as I'm more in the age of being a grandmother myself. It made complete sense. Help your kids to be safe, teach them how to swim, and give them a tool that can open doors for them.
Yeah.
And, it's interesting how I find all these basics coming back. And have a person like you to talk to, it's brilliant because you really, really deeply understand as an SLP the full picture.
That's so great. Yeah. And the back to basics. It doesn't need to be so complicated, like just back to basics. And as you're talking about the book Knows that you're writing, I didn't even know you're writing that book because you've written so many. So can we talk about these
Seven.
books? 7 books. Oh my gosh. Well, there's one coming out soon, and you can talk about this because I'm very curious. And if you can show us, it's called Breathe 4.0. So can you talk about this book and program?
Yes, this is my brand newly born baby.
Beautiful book.
Yeah, almost 500 pages, and it has, I think, 1,000 sites in the bibliography. But it's a consultation book, and it's a book that it's really the syllabus of our whole course that you don't need me for. You can just get it but we will have we have 4 sessions to get certified as a biofunctional therapist, not myofunctional, but biofunctional. And the sessions will give different dates for it. They're not consecutive, so you can take them as you want. And after you've done 4 sessions and you know the material, you can get certified on our Uplock system. But it's really a book that has tabs here, and we have 4 sections. The first one is about the biofunctional model and the Uplock, and it really gives you the basis of everything that Dr. 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐄𝐑 did for 40 years of being the head of his hospital with that triple PhD. And then we have the second part is the second part is the treatment, or the pathology, where we have snoring and we have all the what we call biofunctional treatment. So this gives you this part with the yellows and the reds gives you the part that is for treatment. So you really can take this to a clinician and say, we're snoring and we want to optimize our nose and we want to optimize our mouth. And so that if we need a CPAP, we have a chapter on sleep apnea and CPAP, on mandibular advancement devices. We have a chapter on reflux, because reflux has a pressure component, and we really haven't looked into that. And it's really, reflux is something people are struggling with at any age, from babies. And then we have the health optimization. So one is for therapies for people that are already sick. This is for optimizing health. And this is where we have that amazing chapter on sports. And, I'm very excited to share it. Here we have the running, the stuff we were talking about, and that cycle of how we pull off while we're doing activity. And, when we take air in through the nose, out through the mouth. So this is a cycle that allows us to just maintain levels of, mild movement or exercise during a lot of periods. And then we have this part as an SLP. I think you will enjoy this. This is for professionals. It's the last section on the book. And this part really, I'm really excited about it. And I think we have this whole thing on phonation that we did in Germany. And we have the MRIs and the diagrams for every sound. Oh. And it's an amazing chapter. And Catherine, our SLP at the Uplock Academy, she says this should be required text in any SLP program, because it doesn't exist with the MRIs and with the explanation of how we use pressures, how we use our soft palate for different pronunciations and stuff like that. Yes. For this, we have some templates that come with the book. Okay. So when we're talking about valves and that new language that we're talking about, we can put the line up I don't know if you can see it on the. Yes.
So you line up the clear,
you line it up, and then you can see where the valves are. So here we give you each letter if a valve is open or closed, and then you can see here and see the number of the valve that we're talking about. Same thing with the diagram.
That concept would be helpful with our voice patients or our patients who stutter as well, because I go through and tell them how to relax those areas where they're valving or closing and how to relax them versus getting stuck. So that's interesting.
Yeah, and I don't know if you're familiar with our Uplocker, but the Uplocker really allows us to focus our attention on the valve number 3, which is a soft palate and the back of the tongue.
I don't know. So the Uplock, can you talk about the Uplock method, what that is, and also for orthodontics, which you developed, and what that is? I'm like, quick, we didn't talk about any of these things.
We're going to have to do part 1 and part 2.
I know, we will.
Crazy. But this is our device called the Uplocker. Let me just untangle it here. And the Uplocker is it's a device that gives you feedback on where your soft palate is, or if there's negative suction inside your mouth. And I see online that people are starting to talk about, holding your the space inside your mouth with no air and swallowing and recognizing that negative suction. And then just teaching yourself to hold that suction. And our up blocker, and this is, I'll show you this one I came up with, but let me see if I have them.
And the up lock is a device that measures the negative pressure in the mouth, or
It doesn't measure it, but it gives you an indication. So I'm going to use this one that I made with a toy for the kids. So do you see this bubble here?
Yes.
So when you suck all the air out of your mouth, the bubble goes in.
Okay. Uh-huh. Okay. And your tongue is sucked up to the palate when you're doing that?
I don't like to talk about the tongue
Mhm.
because as a dentist, when you talk about the tongue, the tongue says, "Oh, did you need me? I'm here. What do you need from me?" So if you're drilling on a tooth, you never say tongue. Because if you do, the tongue will actually come. So I try to keep away from saying the tongue. I just say, take all the air out of your mouth, because it's all about the soft tissues being consolidated away from the airway. So when we give this to a child, we say, well, just make sure that this is in. And we have a little, this is a deglutition or a feeding tube that you can buy at the pharmacy. And we just connect it here to our
Okay. So the tube goes on top of the tongue. Is that where it's going?
Yeah, this goes into and this is all explained in the book. This goes into the donder space. So if you put your teeth together right now and you swallow, recognize that saliva goes in the middle between the palate and the tongue. There's a space, and that's where saliva goes, and that's where negative suction is recognized. So this goes in that space. This also can be very, very useful. As I said, well, you're being an SLP, you might be familiar with like video fluoroscopy and the barium, the modified swallow test with barium. Have you ever heard of that? So this helps us also put some material, fluorescent material in that area, so we can see how the swallow is happening. And it gives us so much information that we didn't have before. And we also can teach people to recognize that valve and to start working on getting the pressure. This can be connected also to a manometer, because we need a lot of pressure for the swallow, but very, very light suction for rest. So we teach kids how to hold it. We use videos. We use, things, on the phone that we say, okay, we're going to hold this in our hand. And if this is on, your cartoon will play. And we have 2-year-olds that can do this. That's within those 1,000 days that we talk about. We can teach them to hold no air inside their mouth. When they have no air inside their mouth, their nose is working well. If you, for example,
so it's that negative pressure, this device is giving kind of like visual feedback or sensory feedback that the tongue is gently suctioned, and you call that up lock is the word. Okay. And
yeah, the same thing we have with our pacifiers.
Okay, up lock pacifier.
Yeah, the pacifier, this is the 18 plus that has no nipple, right?
Okay.
And it has this bubble. So when you
the valve goes in, so you put the pacifier in the mouth, but there's nothing on top of the tongue. Okay, but it's detecting negative pressure in the mouth that the tongue is sucked up. Okay.
So you give this, this is a great transitional pacifier, because sucking is important, but when the teeth start coming in, you want to move away from sucking forward to putting the tongue in the roof of the mouth. And when the child realizes that when this bubble is in, they get to watch a 5-minute video or cartoon or something, they start deriving pleasure from basically sucking their tongue to the roof of their mouth. And you can do that. We've worked with patients with Alzheimer's that you can't really explain to them anything. And I had a 97-year-old, she was going to need a feeding tube with my aunt. And so I created a device for her, and we helped her recover the deglutition reflex because she was not closing the valve. So we use this technique. So it's easier to treat a child very young with games and fun things, and an older adult with Alzheimer or even patients that have some kind of neurological
Or
disorder.
aspiration issues or something where they're
Yeah,
actually.
and my mom who's 88, she coughs sometimes, her saliva is going the wrong way. So I have her practice a little bit. And when you recognize it, you can teach your brain to rest with that valve closed. If you can't recognize it, then you don't know.
Right. And that's what I say. About half of the myofunctional therapy is neuromuscular reeducation, but the other half is cognitive awareness, right? We need to be aware. So with that pacifier, nothing like there isn't like that feeding tube small thing going on the tongue. It's just sensing the suction of
Yeah.
when it's around the teeth. Okay.
Yeah.
And then
This is
how do
the
you
way
know?
the up locker comes.
Okay.
And this doesn't go to the roof of the mouth. This just gives you an indication of what's happening inside the mouth.
Okay. So you put it in, it goes around your teeth, and it has that sort of pressure feedback because it's sucked in when there's negative pressure in the mouth. But the lips are relaxed and closed. Okay. So it's not, if you were to suck in with your cheeks, would it sense that?
With not if you suck with your cheeks, without the under attachments, you could cheat a little bit. And you could keep your tongue low, but that with the dunder space you can't because it's measuring exactly what your tongue is doing.
Okay. And how does the patient know that the button is in? Do they feel it's in with their finger? Or you have to be looking at it?
For this, yes. However, we have the devices that we can separate. Let me see if I have one here. I don't have one with me, but we can separate the parts so that you can hold this in your hand away from the patient, like this one, right?
Okay.
This is a device, and it has
Got it. So they can see
yeah.
that, okay,
So
it's the
they
button
can
is sucked in.
yeah. Or Catherine in the office, we connect this to the manometer. We have a manometer that you connect to, and then
Okay.
see the number because you want to have between 10 to 15 millibars of negative pressure. Swallow is 50 to 100, even higher than that. And rest is 10 to 15. So we connect to the manometer, and we use these tubing to
And
do
this
that.
concept is helpful because some patients get confused and they think they're pressing their tongue up. And when we're in correct oral rest posture, it is actually a relaxed muscle tone. Our muscles have tone, but we're relaxed. We're not forcefully pressing, right? How would that ever get to a subconscious awareness level if you're having to actively push? So it's a gentle suction. I would say like a suction cup. So it's kind of like the uplock thought, right? Suction cup of the tongue with that gentle suction, negative pressure at the roof of the mouth, but the face, everything is relaxed. So that's a good marker for feedback for patients that there is that negative pressure, that suction. So that's part of your uplock program, which is explained in the Breathe 4.0 book. Is that correct? Okay. And then can you talk about orthodontics and 𝐃𝐈𝐒𝐂𝐋𝐀? We only have a few minutes left because I know we went over, so we could definitely do a part 2, but I want to not leave people hanging with all of Dr. Kahn's protocols and all of these amazing things you've created. So what is orthodontics?
So forwardonics is the name that we coined when we were writing JAWS. And it really involves anything that will focus on growing forward or developing forward. So instead, orthodontics is very much pushing things back. Anything that actually, any therapy or anything that we have that will help you grow forward is part of orthodontics. So it's just a phrase we coined for the company.
Okay.
That
So
has
like a concept.
yeah, anything that involves forward development, forward growth is within the scope of forwardonics. 𝐃𝐈𝐒𝐂𝐋𝐀 is amazing. I don't really spend enough time. And 𝐃𝐈𝐒𝐂𝐋𝐃 is again going to basics. And it's good oral posture exercises. It's basically 2 exercises. I very specifically don't talk about muscles because when we're talking about breathing, breathing really should not have a voluntary involvement, at least not breathing at rest. It should be controlled by the brainstem, not the brain. And the brain controls our voluntary muscles, our striated muscles. And the tongue is a mixed muscle, but it's also a fluid. It reacts, we call it a hydrostatic organ, which changes its shape but not its volume. So we don't really talk about toning the muscles. And if you really think about, let's say this Ventos, this is not gonna work. But if you put a suction cup and then you try to hold this, you can see that it's very strong. It's not going to need the cup to have any force. It's passive. So that's why obviously we have muscles. We have muscles like, we have a series of muscles that are involved with the brainstem, like the ocular muscles that do the RAM, or the digestive stuff, or there's things that we don't have voluntary involvement with. So when you talk about tone, I'm not saying it's not important, but what we need to notice is the passive suction, and that's irrelevant to our muscles. Creating suction has nothing to do with muscles. It has to do with pressures and closure of a compartment. Yes, a muscle can be closed, but a tone muscle or a lax muscle, it's going to react the same if there's suction inside that compartment. So it's more about really focusing on the gradient of pressures and atmosphere and the gravity and things that are in the universe. And when we talk about things, we want to focus a lot of attention on the swallow. If we correct the swallow, at the end of the swallow, we end up in this position. So it's a consequence of a swallow. And even people that have very low muscle tone, they can swallow. If they can swallow, they can rest in the right position. Tone is important. I'm not saying it's not, but it's not what we're focusing on, and it's not where the bigger change is going to happen. It's all about that suction. And when we know what's happening, we're empowered. So 𝐃𝐈𝐒𝐂𝐋 works with chewing 2 minutes and with reading for 5, or counting for the little kids. And what we focus is on the pause, which is when we're doing nothing. That's the critical part. And Dr. Marisa Santos, I don't know if you know her, that's somebody you might want to interview too. She's our 𝐃𝐈𝐒𝐂𝐋 whisperer, and she does all this online. She can even work with kids that are 2 years old, and she does it online, and she has a 90-day program, and it really, really changes lives. If you can get the kids early into those good oral posture situations. And if they can't do it, it's because their nose is not working. So then you will know, but it's all about the pause. All our exercises are not for tone. They're not for building muscle strength. They are for understanding how we pause, which is how ultimately we're going to rest. That's
You mean pause after the swallow? Is that okay? What about somebody who has like a very forward tongue thrust? So they're getting the suction, but the tongue is in the incorrect position. You help them angle the tongue back and get in correct posture.
Well, the tongue thrust is it's really an oxymoron, because we don't have a tongue thrust. If we understand the new language from Breathe,
Breathe 4.0 book.
yeah, we know that the lips are valve number 1. The front of the tongue, which is a U, it's not a tip, it's a U. And the back of the throat, the back of the soft palate to the tongue, that's valve number 3. So if we think of valves, what's a tongue thrust? It's not a tongue thrust. It's the valve number 2 is inefficient. So valve number 1 has to come in against the tongue to create that suction. So somebody has a tongue thrust is really, and we've coined that term, and it's been published in the JAOS. If you want, I'll send you that article, because we coined the term OVDS syndrome, and that's oral valve disorder syndrome.
Okay.
And that is what a tongue thrust is. So you're not thrusting the tongue. there's a problem with the valve. There's a dysfunctional valve. So all you need to do is create an environment where the valve can really do its job correctly. And the tongue needs space. And if you don't create space, the tongue is going to go wherever the tongue needs to be, either in the throat. And I did a consultation just 2 days ago with somebody, and the kid had this rake in the palate because of tongue thrust. And I just told him, get this out now. I can't deal with it, because why are we doing this to the tongue? It doesn't make any physiological sense. We have to evolve. I use those tongues, and I use the ones that had the sharp prongs.
Yeah.
Of the protection mechanism, so they don't get hurt, then it stays back.
Yeah.
But it doesn't make any sense today. It did,
Right.
I went to school 30 years ago, even longer. But it made a sense 30 years ago. It doesn't make any sense with what we know now.
Right.
So I would actually erase tongue thrust from the vocabulary.
So as like to correct the valve closure, to valve off at the correct place, you would do some muscle training to get that muscle alert tone, to cognitive train. Like what is your thought on how to stimulate the closure of the correct valve versus compensating with forward posture?
I don't, even though in orthodontist in the protocols, I have 3 myofunctional exercises, or what we call, complementary exercises. I don't really think muscle exercises are useful. And I say that with the empathy of somebody that survived years of myofunctional therapy with my children. It's not conducive to train the tongue. You have to create an environment. There's a great book. I don't know if you're familiar with the Heath brothers. It's called Switch. Have you heard of that book?
No.
They wrote one called Made to Stick, and another one called Switch. And they say there's no amount of rational that will get an emotional to do anything. And they use the analogy of the rational is a rider and the emotional is an elephant. And the rider can never, ever, ever convince the elephant to go where the rider wants, with no amount of rational information. The only way to change when change is hard is changing the path, making the path easier for the elephant. If you work on the path, the elephant will follow that path. So we try at orthodontics too. This sounds like a sales speech, but we try to work on the path. And if you cannot teach the tongue anything because it's an elephant, and no amount of work is ever going to teach the tongue to regain the muscle force to do something, because the tongue will passively do whatever the suction tells the tongue to do. So you need to make sure that you understand what the lips do and where the tongue will go naturally if the lips are closed. And you need to have enough room. If it's early, the tongue will create the room. Dr. Rangel says, form follows function during growth. When growth is complete, it reverses. And function will always follow form. So if you don't have a good palate and your tongue has nowhere to go, it's going to be very tough. But if you have one of those open bites and the tongue is sitting in between the teeth, when you use something like this pacifier that has a shield here, and the tongue naturally, when you suck, then where is the tongue going to go? Up, right? The tongue is not making that decision. You see, this is a shield between the teeth here. So if you have an open bite and the tongue cannot sit in between the teeth, the tongue is just going to go up, and the teeth are going to erupt in the right place. So the open bite is closed. And any orthodontist, any pediatric dentist knows kids that suck their thumb or have a pacifier, the moment they leave it, the teeth just close down. Because it just, if it's at the right age where things happen, organically, the palate will lower itself and widen, and there'll be no problem if you get the pacifier out before 2 years old. The open bite is just closed. But we can have exercises and we can have things to focus our attention on getting that suction and getting the tongue to naturally go where it needs to go. You don't put the tongue there. If you close your teeth now and you swallow, your tongue naturally goes to the roof of the mouth. That's why I'm not saying frenectomies are not needed. You're an SLP, so you tell me if they're needed for speech. But to get your tongue on the roof of the mouth with your teeth together, the frenum doesn't have to go very far. And it's just about sucking the air out of your mouth. It's not about moving the tongue. The tongue is a passive writer. And so if you have a tongue thrust, it's a dysfunction of the valves. So what do you need to do? You need to use some kind of, we have the lip locker, which is just a silicone shield. And you wear it as much as possible. And that allows the lips to relax and close. As long as you don't have a huge, jaw discrepancy, you teach the lips how to be relaxed. Also, forcing the lips to have strength it doesn't make any sense. And I have a great series of photographs of people that have been using the lip locker and how their lips all of a sudden they stop being thin and tight and they just start getting volume. And older women like me would love that, because when you teach yourself to hold your tongue and only put force inside the mouth and relax the lips, the muscles just, express themselves.
Mhm.
And a lot of people have this tight lips and they're always trying to close their mouth with force. And it's not about force. It's not about training muscles. And the tongue thrust is not about the tongue. It's a valvular problem. So let's address the valves.
That's an interesting concept, interesting way to think about it. It kind of changes the like a perspective of how to think about these things and maybe how to teach patients. So let me see. I want to summarize what we talked about, kind of bring it all together. And you are writing a new book called Nose, or we don't know exactly what's going to be called, but NOSE book. And we will be excited to hear about that. But the concept to get across is how important the nose is. The nose is primary. We must help our patients get to an ENT or some way to help their nasal patency and not ignore the nose. So that is extremely important. We talked about giving the nose priority. I have so many notes that I wrote here. We talked about you have the nasometer, which is measuring pressure, not flow or resistance, but pressure. We talked about the Starling model, which is really important for all of us therapists to know and understand and to teach our patients. Why not? If you look it up online, you see it's a tube, it narrows in the middle and then widens again. And our nose is the
It's not
solid.
really narrows. It's
It's,
flexible.
it's flexible.
Yeah, it's rigid, flexible,
Flexible.
rigid.
Rigid, flexible, rigid. So nose is rigid, pharynx is flexible or collapsible, trachea is rigid again. And so the area of collapse is going to be at the pharynx, and that's going to be way more likely to collapse when we have nasal resistance beyond a certain amount of what's normal.
Yeah, and this is why UPPP was a failure, because it's not a space problem. It's a
Yeah.
collapsibility problem.
Okay. And interesting, the first 1,000 days is up to the age of 2 because we have to think about fetal development. So that's an interesting, important way to look at that. We have 20% genetic, 80% environmental with our changes in our structure, which is really important to think about. So yes, genes play a role in nature, but a huge percent of the changes of our face are due to nurture. And you are coming out with the book Breathe 4.0 soon, which is already, you're almost ready to get that done with. I think
Available already. It's in the flesh.
it's in the flesh, and you could people can pre-order that book from you, which is like at cost for if you pre-order it. 500-page book, beautiful book, and that talks about your program and your thoughts and concepts with the up lock, and that up lock method is talking about pressures, thinking of the oral cavity and breathing as a pressure system, like physics, airflow, and issues with tongue pressing forward or thrust that we might call it. You view it as more of a valve system and talking about closures or valves and dysfunction of the valves. And you have devices like the uplock pacifier and the uplocker and different things to help patients get feedback on, are they having negative pressure in their oral cavity, getting that tongue sucked up with that negative pressure, that valve closure, which is a good feedback mechanism for the patients with the uplock devices.
And I will send me your address. I will send you one of these for you
Yeah,
to.
that would be great for me to test that out and to work with some patients with that. For orthodontics is just the concept of developing everything forward. And the 𝐃𝐈𝐒𝐂𝐋𝐀 is your program that has different oral posture exercises, but really focusing on the pause after the swallow, that negative pressure. When I work with my patients and we get to the saliva swallowing aspect of therapy, I always have them stop after they swallow, feel where your tongue is. Are you back in that rest posture? Because it just stay there. Like, don't go ahead and drop your mouth open, drop your jaw, drop your tongue, stay in that pause. So that is a concept that I use with my patients as
Yeah,
well.
I love SLPs, but second in line are the physical therapists. And Jenny Hobson, I don't know if you know her.
Yes, of course.
She coined the term invisible swallow.
Mhm.
And it's really, I mean, the way she teaches it is great because we now use a syringe with our manometer and we give the patients a mirror and we say invisible swallow and they
Yeah,
get it.
right.
So working with the SLPs and with physical therapists, it helps me as a dentist to see things from a different angle. And you guys get it so well.
We'll all be seeing you at a conference coming up soon, and my husband's a physical therapist, so we can have a great
Oh,
conversation.
you're a great team.
Isn't that fun? But yeah, the concept to think about swallowing in your mouth, think about pressure and valves does take it to a different level, not just muscles and tone, but pressure and valves. So it's a good thought and concept for us all to put in our minds. And I really appreciate your time. I know we spent a lot of time together, so I really thank you for
No,
all.
I think you, and you can split this into two separate, because I think we've done like 2 hours. Or an hour and a
We've done
half.
an hour and a half, I think.
And split it into two, or I'm happy to come back and talk about more things. But I certainly will share the PDF of the book with you, and I
Okay.
will send you a device to test drive.
And we'll let everybody check out your website, which has all your products and information. And thank you for all the work and the research you do in the field and the airway orthodontic field, the 7 books, multiple articles. It's we really value all of your time and energy in doing all of those things. So thank you so much, Dr. Kahn.
It's been a joy talking to you. I do a lot of interviews like this, and the knowledge that you have has blown me away. I
Oh,
think people are lucky to be your patients. And if you have a physical therapist in the family, I'm sure you're in the forefront of really seeing the patient as a whole. I complain with my doctor friends that they see patients with no mouths, but we see mouths with no patients.
got to put it all together.
It's up to you guys, because
Yeah.
we can't do it ourselves. You
No,
need to
it's a
be
team.
middle.
It's a team.
I am a survivor. Being an orthodontist, I'm a survivor. I was all over the place. I had years of sleepless night, not knowing what to do and requiring things for my children that were absurd. And I don't want that for parents. And parents are insane right now. So they really
Yeah.
need to be told, you do this,
Yeah.
this, and this, and shut up. They
Yeah.
need to have people with authority like the SLPs telling them and not babying everyone and not welcoming everybody's ideas of everything.
Yeah,
But
it's
using
it can be
science.
confusing. Yeah, there's a lot of practitioners. It can be confusing, even within each field, like orthodontics, ENT. There's many different opinions, so patients get really overwhelmed and confused. And hopefully, one of my roles here in doing this Airway Answers is helping people understand and be able to make decisions and be less confused. So thank you so much for your time. I appreciate it again.
It really, I cannot repeat it enough times. It's been a really, a real pleasure to talk to you.
Thank you. I'll be seeing you at a conference soon.
Absolutely.
Thank
I'm
you,
going to
Dr.
be
Kahn.
blogging you an email for sure.
Okay, sounds great. We'll connect. Take care. Thank you. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.